Welcome back to the Benefit Whisper, the podcast where we break the silence on what's happening in healthcare and benefits. I'm Ralph Weber, host of the Benefits Whisper, and today we're diving into one of the biggest elephants in the room, prescription drug costs. We have a few episodes on this because it's such a huge issue. Why does the U.S. spend more than any other country on earth on healthcare and on drugs? And we talked last episode with Benjamin Jolley about how New Jersey saved, I thought it was 25 million to 100 million, but it turned out even more. It turned out to be $1 billion. And how you can do that. It's all in the contract wording. So once again, our guest is Benjamin Jolley, somebody who is a pharmacist himself, has the oldest pharmacy in Salt Lake City, and has been on the forefront consulting with employers, with pharmacies, about pharmacy benefits. And he has a lot of information to share with us today. So welcome back, Benjamin Jolley. Happy to have you.
Thanks for having me. Glad.
I was so fascinated the last time we spoke about the state of New Jersey saving $1 billion on pharmacy spend for their state employees, which is just amazing. It's just by changing the wording. Some of the markups that you talked about, the spread pricing, $140 drug becoming an $1,800 drug, to mention one. We know that there are now 10 drugs, I think, that are over $1 million each, which is crazy. I think the top one is $4.25 million. Do you know about some of those most expensive drugs?
Only by the news headlines that I read.
Yeah.
I don't dispense those medicines. I'm not allowed to by most pharmacy benefit managers.
Right. No, and they're ridiculously expensive. Now, last time, you alluded to something as simple as adding baking soda to a pill changes everything, changes the cost. Why don't we start there?
Sure. Medications, there are about 2,000, 3,000 active ingredients in prescription drugs in the United States. There are well over 100,000 national drug codes. So that means that, like, if you take a drug product, and the way that pharmacy benefit managers price drugs, they group them into so-called GCNs or GPIs in most cases, and then they'll set a price for that group of drugs. But usually that generic code number or generic product identifier will identify a drug to, like, what's the active ingredient, what's the strength, and then you would group whether it comes in a 1,000-count bottle or a 30-count bottle. They'd be the same price, theoretically. Even if the pharmacy has different pricing, you would just pay them the same, whether they buy it in a 1,000-count or 30-count. Doesn't matter. But there can be very slight differences introduced by pharma companies to get a new drug and have their drug be a different product from the perspective of a purchaser. One example of this is a product called Zegerid, is the brand name of it. It's Prilosec or omeprazole with a gram of baking soda added. So it's a capsule that's a little bigger physically than an omeprazole capsule, because omeprazole, you get 20 milligrams, and you add a gram of baking soda to that, and you need a little bit bigger of a capsule. Anyway, omeprazole is a very common medicine, commonly prescribed for acid reflux and other diseases. But many employer benefit plans, many other types of plans will cover both omeprazole and Zegerid as covered benefits. For several years, there was a consultancy in the pharmacy space that would help pharmacies identify these kinds of, I call them scams. I think they are scams, but identify these kinds of relatively simple switches to be able to earn more revenue.
So let me make sure I understand this. The active ingredient is the same dosage.
You add baking soda as another active ingredient, but
you add baking soda, which is not a patented drug. It's something that's very common. You could do it yourself. You could really, literally, if you wanted to, add a gram of baking soda. And does it have considerably different outcomes, different side effects? Does it change what the drug does substantially?
So you're trying to block acid, right? So being very generous to the manufacturer of this drug. If you're trying to block acid, anyone who went to an elementary school science fair has seen a volcano where you take baking soda and vinegar. Vinegar's an acid. It neutralizes the acid and produces carbon dioxide, right? So baking soda does neutralize acid. So it makes sense from a chemical standpoint that if you want to block acid, you would use it. But that's not why it's there. It's there purely to just say this is a different drug. It's not omeprazole, because it doesn't have a meaningfully different outcome of how effectively we block acid, omeprazole by itself more or less blocks acid from being produced like 95%. The results you get from this is the typical payment to a pharmacy for omeprazole is somewhere less than $20 for a month's supply of medicine. It might be as low as $4, which I think is unjust and underpayment. It might be, in some cases, it might be much, much higher. There's good evidence of that in the TRICARE program, that the administrator paid their own pharmacy the full average wholesale price of the drug, which is $600.
Wow.
But that's neither here nor there. The
Right.
point is, Zegerid, you add this gram of baking soda, and the average wholesale price jumps from $600, so the suggested retail, as it were, to, I think, $2,000 for the same number of capsules. And
Wait. I think I misunderstood. It jumps from 600 to how much?
2,000.
2,000, just for adding a gram of baking soda.
Right. For
Wow.
the same number of capsules. That's the average wholesale price, or suggested retail is how you should think about the term average wholesale price.
Right. Okay.
And the typical PBM payment to a pharmacy might be well over $100, where omeprazole typical payment is $20 or less. The payment for omeprazole with bicarbonate in it is as high as $1,000. And
it goes from 20 to 1,000.
Right.
Wow.
And this could have been tamped down over the last few years. Maybe the prices have been pushed down, but still, the price differential does still exist. And like this kind of thing happens all of the time in pharma. And
what can an employer do about that, Benjamin? How do you audit for that? How do you stop that from happening as an employer?
Yeah, I mean, so you can instruct your pharmacy benefit manager to put in place some kind of utilization management requirement on the more expensive formulation, the one with the bicarbonate in it. You can say, and for what it's worth, the Zegerid is actually now also available over the counter for like $20. So
wow,
it's not like it's inherently more expensive. I mean, baking soda is incredibly cheap. The drug is pretty cheap. So you can put a formulary exclusion, just say this drug isn't covered. You can put a step therapy requirement to say, I mean, these are very standard pharmacy benefit management tactics, right?
Right.
Say, give me evidence of what, like, you can put a prior authorization requirement in place and say, hey, let's say you have to send me paperwork if you want to get this versus just regular omeprazole. You can put in place a step therapy requirement to say, show me evidence that the person started omeprazole and it didn't work, and then we'll cover this. Fine.
Right. Okay.
But, all of those methods are good methods, but like this isn't the only drug like this. There's another one called Vimovo that you may have heard of. Vimovo is a mixture of, if I remember right, naproxen and famotidine. So naproxen is just very similar to ibuprofen in terms of its effects, and ibuprofen and all of those kinds of pain medicines can cause stomach ulcers. And so the concept of the drug is, well, we're going to say it causes stomach ulcers, so we're going to put an acid blocker, famotidine, in with it to protect the stomach lining. Well, then you'd get naproxen, that usually is, again, one of these $20 or less a month drugs, to Vimovo that has, if I remember right, an AWP of something like $1,600 a month, and commonly payments in the $100 to $1,000 range. These kinds of like scammy drugs happen all the time. And it's a constant game of whack-a-mole for employers and purchasers of prescription drugs to watch out for this.
And is this something where a good PBM would be a better advocate in terms of sorting that out for the employer so that they're not paying for these more expensive drugs unless they really, really, really have to?
Yeah, I mean, like a PBM that has a well-designed formulary would have exclusions and restrictions on these products, because they are products that exist to be sold, not to be for therapeutic reasons, right?
So, okay, makes sense. So if an employer has that expertise in staff, pharmacists, et cetera, should they participate in designing the formulary?
Okay, for sure. Like if you've got a large plan that you can hire a pharmacist to do the work of designing the formulary, you should absolutely be designing the formulary.
For yourself, not for the PBM. Gotcha.
Right.
Okay. Now, speaking of that, that's a good segue for us, Benjamin. We spoke about a relatively recent lawsuit that was filed. There were 3 that were filed. One has been partially revoked, but not completely. The 3 are the lawsuit against Johnson & Johnson as an employer, Wells Fargo as an employer, and JP Morgan Chase as an employer. So these are the three fiduciary lawsuits which allege fiduciary duty as having been neglected by the CFO, CEO, CHRO, et cetera. Let's talk about the JP Morgan, since that's the newest one. Are you familiar with that lawsuit?
Yeah. I mean, the general principle of all of these lawsuits is the same. It's basically saying that anytime a employer fails to properly manage their PBM relationship or fails to select a PBM in an unbiased manner, they are breaching the duty of care and the duty of trust that fiduciaries owe under the Employer Retirement Income Security Act of 1975.
ERISA.
Yes.
Right. So employers have to be very careful that they are following the ERISA prohibited transactions and that they're very familiar with that. And the larger the employer, the more important that becomes.
Right. The amount of money on the line is more, and the opportunities for abuse by vendors is more rife. So the JP Morgan lawsuit alleges that the management of JP Morgan, in especial their benefits administrator who signed all of the ERISA forms to the IRS, breached fiduciary duty by not managing Caremark, their selected PBM, to properly ensure that prices paid were appropriate, that vendor selection was done appropriately, and they give an example of a medicine with an ultra high cost AWP. The drug in question, if I recall correctly, is teriflunomide or Albagio. It's a medication taken for multiple sclerosis. And when it was brand name, if I remember the numbers right, it had an average wholesale price, so again, suggested retail, of nearly $20,000 for a month's supply.
$20,000.
And it has since lost patent exclusivity. So the manufacturer of Albagio no longer has significant market share because many generics manufacturers have stepped into the space. But due to just the structure of how suggested retail or average wholesale price is set in the pharmacy space, all of those generic drugs, almost all of them, still bear AWPs in that same range of nearly $20,000 a month. And so, despite the fact that a pharmacy can obtain a month's supply of generic teriflunomide for very little money, the lawsuit points out that it shows a screenshot of a explanation of benefits for a JP Morgan Chase employee who received Albagio generic from their contracted specialty pharmacy, which I have to assume was CVS Caremark Specialty. I don't know that. But it showed a payment was made on by the employer benefit plan to the specialty pharmacy of $6,227 for this medicine. So that's a significant discount from $20,000,
Yep.
right? And that's how PBMs frame it, is we'll give you all of these discounts from the average wholesale price.
Right.
But they point out that if you go to Rite Aid, you can get this medicine for $32.35 for
$32. So the suggested retail was $20,000. They sold it for about 1/3 of that, 6,000 and change, to 65% discount approximately. But that can actually be obtained for, did you say $30?
Rite Aid will sell it for $32.35 according to the lawsuit.
Wow.
I believe this is a GoodRx discount card that they were actually referencing. Wegmans for $29.35. And then if you go on Mark Cuban's costplusdrugs.com, you can apparently get this drug for $11.10.
$11, and they charged over $6,000 to the employer for the same drug.
Right, exactly.
And I love what Mark Cuban's doing with GoodRx. You know, the concept is, here's the cost of the drug. We're going to add a dispensing fee, which is reasonable, plus 15%, or 15% plus a dispensing fee, obviously to cover their costs. I have no problem with that. Makes perfect sense. But he's bringing so many drugs to the market for so much less. So $11 for a drug that an employer was charged $6,000 for.
Right.
Wow.
And so, like, that's the headline, basically, of the lawsuit. And then it goes on to point out that for generic drugs across the board, the plan was paying something like 3 to 4 times what pharmacies typically are paid for generic drugs.
Right.
which was either pocketed by CVS Caremark as spread or paid out to pharmacies as overpayments, in effect, compared to what the pharmacy should have been paid in a just system. Wise, it costs pharmacies about $10 to $15 a prescription to process a prescription and get it out to the patient. And so when you're thinking about what should it cost to operate a pharmacy, that's the number. And so anytime a plan is paying less than $10 for a drug, that's being subsidized somewhere, right?
Okay.
If you're paying $4 for a drug, then the pharmacy is losing money and they'll be making it up somewhere else. Or that pharmacy will just go out of business, which is very common, unfortunately, today. But so you should view that as like the very bare minimum, and then you have to add the cost of the drug itself. But the cost of drugs themselves is a lot lower than these AWPs or suggested retails.
Right. So
And
let's
so,
talk for just half a second without, because this could be a whole episode on its own. AWP versus acquisition costs versus NADAC, like rough numbers. Can you break it down, the difference between them?
So look up on Google this NADAC equivalency metrics, NADAC equivalency metrics. So the national average drug acquisition cost is a survey put out by a company called Myers and Stauffer, where they say, "Hi pharmacies, how much did you pay for drugs this month?" And pharmacies voluntarily submit the data. They have no authority to demand that they submit it. So pharmacies just submit the data because they want to be paid fairly. So Myers and Stauffer then takes the various invoice prices paid by pharmacies and just averages them, and then comes up with this drug costs 13 cents a pill. This drug costs $6 a pill. This drug costs this much per pill. And then Medicaid pays pharmacies on the basis of NADAC plus a dispense fee that covers the cost to do business of a pharmacy. It costs $10 to $15 a prescription to dispense a prescription, then that's what Medicaid pays. It's a very simple to understand system. You pay the cost of the drug plus the cost to dispense at the end.
Right.
And so when you look at NADAC and you compare it to these other benchmarks, AWP, wholesale acquisition cost, Myers and Stauffer actually does this on an every quarter basis and says this is how much the NADAC is compared to the AWP, compared to the WAC. And they do a chart for generics of how many companies produce this generic drug. And just when there is only one company producing a generic drug, the national average drug acquisition cost will average something like a 40% discount to the AWP.
Okay. When there's only one manufacturer of the drug.
Correct.
The
so
average
the AWP
is 40% less than AWP.
Correct.
So if the AWP is $100, you could expect to pay $60.
The pharmacy should expect to buy it for $60, maybe even less. That's the average. And then when you add more competitors, so more and more competitors come into the market, when you get down to 11 companies or more are competing, that's the maximum they do, the discount to AWP is something like 95%.
Wow.
So this tells you that AWP is not a meaningful number, right? It's especially in the context of generic drugs. In the context of brand drugs, AWP is just a fixed markup to what wholesalers pay to manufacturers for drugs.
So AWP is the maximum they can gouge for? Is that
basically, yeah. It's
wow.
All I want to get paid, I guess.
Wow. That's amazing.
So it can be a very large number.
And how does spread pricing fit into this formula?
Generally, the way this works is that the AWP is the very maximum that a pharmacy would be paid ever.
Okay.
And we just discount off of that. Different PBM pharmacy contracts will discount different amounts as a baseline, as like a ceiling price. You might see AWP minus 30 as a baseline. As for a generic drug, this is the most we're ever going to pay you. Some contracts pay pharmacies less than that, but that'd be a ceiling. And then it's or a proprietary list that we manage called maximum allowable cost. And the vast majority of prescription drugs are priced using maximum allowable cost, which is just a price that the PBM comes up with and says, this is what we're going to pay you. Theoretically, it's based on acquisition costs, but who really knows? And so This is how pharmacies are paid for drugs. And the general concept for spread pricing for maximum allowable cost is that the higher the AWP, the higher the payments are going to be. And in the example I gave you in that last episode, the pharmacy was paid something a decent margin over their cost for metformin. That particular brand of metformin cost them something like $100, and they were paid a total of like $200. So $100 margin on a drug is great, but it's nothing compared to what the PBM then charged the plan, which was nearly $2,000, because they were taking the AWP, knocking off 75% and saying, look, we've got you this 75% discount. Aren't we great?
Right. But discounts are meaningless because the
Right.
starting point is
a meaningless number.
exactly.
It's a made-up number that is usually what the brand manufacturer was charging for the drug before the drug went generic.
I see.
That's the way that I think about it.
So an employer looking at a contract shouldn't judge the contract by discount over AWP, because that's in essence meaningless.
Absolutely not.
I recently spoke to an employer that had more than 20,000 people on their plan. They're paying an average of $230 per person per month. And I think in the last episode, you said that the average numbers are about 125 per month. So almost double that they were paying. Now, Benjamin, you talked about the JP Morgan lawsuit, allegations about the consultant. You want to talk about what it says in that lawsuit?
Yeah, this is one of the more shocking things to me as a pharmacist who is regularly getting paid like $10 or less to fill prescriptions in total. That includes the cost of the drug,
cost of the bottle, the cost of putting it in
Right.
there, the cost of you speaking to the patient, telling about the interactions, et cetera, et cetera.
Yeah. So like I'm dispensing drugs, I'm getting paid a margin of less than $10 on most medicines. Every once in a while we hit the jackpot, but very rarely. Really frustrating. But reading through this lawsuit, it states that in some cases, employee benefit consultants, so probably your big four, they don't actually name names, but your big four consultancy firms, apparently it alleges that in some requests for proposal, they would exclude PBMs from the RFP, not allow them to submit a bid unless they agreed to pay the benefit consultant company a kickback of somewhere between $1 and $7 per prescription.
Wait. Just to be in the RFP process, they have to agree to pay between $1 and $7 per prescription.
Yes.
To the consultant.
Right.
Now, are these fees disclosed?
Apparently not.
Can you find them on the 5500?
Apparently not. They're just concealed inside of the spread pricing that the PBM collects.
Okay. Wow.
And there was a specific allegation of an RFP happening where the benefits consultant demanded a kickback of $6.50 per prescription. And if you didn't agree to pay that, you would just be excluded. If you did agree to do it, you were to mail it as a quarterly check to the benefits consultant at a P.O. box in a different state.
Wait. The benefit consultant was in one state, and you have to mail this quarterly kickback of $6.50 per prescription to a P.O. box in a different state.
Correct. Yes.
How is that legal?
I don't know. I don't know that it is.
Right. Hence the lawsuit, I guess.
Right. And so one of the things that employers can do as just a check to make sure that they are not being given bad advice is insist on, in any RFP process for PBMs, a question be included in the RFP of, are you paying my if you are the PBM participating in it, are you paying the PBM, are you paying my broker to be included on this bid?
So when you do an RFP to PBMs, you ask the PBM specifically, are there any fees being paid to my broker in this contract? Should you receive it? Wow. Okay. And that's probably left out a lot of times.
Right. And just putting that question in there, a friend of mine insists on this question whenever he's doing RFPs. He runs a consultancy called Granite Peak Advisors based in Montana. And he insists on this question every time and finds that a remarkable percentage of the time, when you include that question, the largest PBMs will simply not submit an RFP. It's an important thing to just bear in mind, is that the person giving advice to the to the like fiduciaries of the plan may themselves be receiving payments from the PBM to bid. And so you need to just make sure that you are, as an employer, that you're questioning this. And because as the employer, you are personally liable. That this lawsuit is not just against JP Morgan, it's against the individual executives who signed off on the plan
Individually
document,
liable. Wow.
who are
Okay.
personally liable to make whole the plan for losses. Like every time they were paying $6,000 for a drug that could be obtained for $32, they're personally liable to make the plan whole for that $6,000 loss.
Unbelievable. Wow. Wow. So the moral of the story is get a very good contract, write your own contract, have your own lawyers and pharmacists review that RFP and the contract before you commit to anything.
Absolutely.
Excellent. Well, Benjamin, it has been a pleasure again having you on. I would love to have you on another future episode soon. If people want to talk to you about what you do, how can they reach you?
Sure. So I am available at apexpharmacyconsulting.com. My email is benjamin at apexpharmacyconsulting.com. I can be found on LinkedIn as just Benjamin Jolley, Facebook. I also write a Substack, just benjaminjolley.substack.com. You can read about the adventures of running a pharmacy and the frustrations that I face in that job and the weird crap that I see.
Thank you so much for being on the forefront of this, for coming out and talking to us, sharing this with your audience. I'm Ralph Weber of The Benefit Whisperer. You can reach us. You can reach me by email, ralph@thebenefitwhisperer.com. You can call us at 832-924-3300. Make sure you like, subscribe, and share our podcast. We will have guests such as Benjamin Jolley, who's been on 2 episodes with us now, and other guests to talk about pharmacy and other matters pertaining to benefits. So again, Benjamin, thank you for being with us today.
Of course. Thank you. Have a great day.
You too.